And so within that context, we were working on disease exposure preventions, which on a everyday basis, we deal with things like tuberculosis and meningitis and influenza, a whole litany of diseases. And so within that context, of course, COVID-19 came around in the early part of 2020. And so it kind of fit right into that same scope where we were already talking about these things in terms of preventative measures and leading indicators and exposure prevention. So when COVID-19 came around, which the date stamp is about January 22nd, was the first time I had gotten asked to come to the incident command system where we were standing up for that. And we started working specifically on the COVID-19 response.
Our mission, and we choose to accept it, is zero injuries and zero environmental impact. A healthy workforce and environment is key to our nation's continued success. The Mission Zero podcast is a deep dive with the industry's top experts into the health, safety, and environmental aspects of today's workplace. Our mission is to be a platform for new ideas and strategies that, when implemented, will improve our safety, our environment, and how we govern our business. We are making the world safer, and we're going to have fun doing it.
Welcome back, everyone, to the Mission Zero podcast. I'm your host, Jeff Peoples. We are recording today in the Flecha Azul Tequila studio. And as my guest today, I have Cory Worden, the City of Houston Safety Advisor. Cory has a Master of Science in Occupational Health and Safety from Columbia University and a PhD from Capella University. Welcome.
Oh, thank you. Appreciate the invite.
Yep, I've wanted you to come on for a myriad of reasons. Obviously, the topic for the past year has been COVID, and you're kind of has been the Houston's front man for this charge and how to handle it and how to test for it and how to precaution the city and all of its myriad of departments on how to prepare and how to deal with this. And first of all, I wanted to ask you before we dig into this, how's your family doing? I know you had a little bit of a sickness with them. Oh,
they're doing a lot better. Thank you.
Good.
Thankfully, it's not COVID-19.
Very good. Yeah. Well, okay. So first of all, just a little bit, if you don't mind, for our audience, just tell us a little bit about yourself, your background, what led you here, and some of the things you've done in the past, and a little bit about your current position.
Sure. Thank you. So kind of the short version is about 17 years ago, I had graduated from University of Houston, and just within a matter of weeks later, I joined the Air Force. It was, shortly after 9/11 and the Iraq invasion. And so I went into the Air Force under the emergency management career field. So what that means is the first couple years I was in counter-chemical, biological, radiological, and nuclear response. And then from there, I went into emergency management, proper, if you will, which is Emergency Operations Center, and doing emergency management planning, training, logistics, all the type of things that FEMA does, except within the military context. And so when I finished my enlistment, which was in 2009, I stayed for another year as a DoD contractor. And then after that, I came back here to Houston and went into safety, health, and environmental, kind of a tangent from what I had been doing, more related to the counter CBRN more so than the emergency management, which, in the civilian world, emergency management's its own construct, separate from safety, which is interesting as to what I'm doing now. So from there, I went into safety. I was a safety coordinator under manufacturing and construction. And then from there, I actually went to the city in 2011. And at that time, I was working with Public Works, Engineering, and Parks and Recreation and the library system. And then I was recruited by Memorial Hermann in 2013. So I went to Memorial Hermann for 5 years. Then in 2018, I actually stepped away for a little bit. I had some personal illnesses and some family tragedies. And so I spent a year doing, advocacy work with National Safety Council and ASSP and AOHP, a lot of work there, a lot of writing, and a lot of leadership with regions and divisions. And then in 2019, I reapplied to go back to the city, and thankfully they took me back. And so I went to work there, and this time I was assigned to the health department. probably because I had a lot of experience with Memorial Hermann, so healthcare goes into public health well. And so I got back over to the health department and immediately began working on our safety management and continual improvement. So we were working on continuity with the safety committee, making sure our hazard analysis was updated and everything was comprehensive, putting the hazard controls and the needs assessment in place, communication program, developing leading indicators, getting all of those things formalized and proactive, developing metrics around that, all the lagging indicators, all the rates and metrics, and of course, working on improvement with analyses and going from there. And so within that context, we were working on disease exposure preventions, which on a everyday basis, we deal with things like tuberculosis and meningitis and influenza, a whole litany of diseases. And so within that context, of course, COVID-19 came around in the early part of 2020. And so it kind of fit right into that same scope where we were already talking about these things in terms of preventative measures and leading indicators and exposure prevention. So when COVID-19 came around, which the date stamp is about January 22nd, was the first time I had gotten asked to come to the incident command system where we were standing up for that. And we started working specifically on the COVID-19 response. Then shortly after that, the Office of Emergency Management had started putting together subcommittees to work on the same situation. And so I began working with them as well. And that kind of put me in touch with a lot of different people and a lot of different departments. So we were working on all the different processes and the way that the pandemic factored into the operations of all the departments within the city. So then from that point, it became, there's the entire emergency management construct tied into what I do. So I kind of became the safety officer in a lot of respects. And then that led into our testing operations, which started with mass testing at the stadiums. And then from there, it went into community-based strike team testing, if you will, targeted testing. And at the same time, we were working on a lot of different partnerships and a lot of different contracts with a lot of different providers that are still around the city working on the same issues. And then from there, we went into doing a lot of work and a lot of advocacy with different organizations, a lot of external organizations, so we could help with planning and prevention and long-term recovery in terms of reopening businesses and getting things to where we could do events and things of that nature safely. And of course, all of those things tie into the same level of preventative measures. And so we were getting things to where they could be done as safely possible. And then that, of course, transitioned into the vaccinations, which started in December of 2020. And we're working on that as hugely right now. So we have a lot of very large vaccination sites up to the NRG Stadium, where that's a partnership between the health department with the city, the Harris County Public Health, the DoD, which is the U.S. Air Force, is a lead on that. There's an entire wing of airmen over there, and a lot of good things happening there, along with the other vaccination sites around the city. So all these things kind of tie together in a way. So it's really exciting, and in terms of being able to really put a dent in the pandemic and try to get out of that as safely as possible and prevent any unnecessary, well, they're all unnecessary, but prevent exposures and absolutely prevent loss of life. So we've done a lot of work on that, and we'll continue to. So that's kind of the short version of how it all tied together. Just a couple things for my due diligence. I appreciate the nice intro. I have a Master of Science at Columbia Southern University. Okay. And my PhD is actually all but dissertation. My dissertation is complete, but I can't claim to have processed it because my degree plan actually got canceled by the college. So I've completed all the coursework and my dissertation's done, but it's not stamped. So I just want to make sure I put that out so nobody thinks I'm telling fibs.
Oh no! Well, that was me that told it, but we'll consider it. We'll consider it a done deal on this show. But so right around March 15th, almost a year ago to the date, Judge Hidalgo put this, I think it was shelter-in-place order in. You kind of revealed just a second ago, you guys were already working, like the teams were already there a full almost 2 months beforehand. Early on in the early stages, you revealed to me just a few minutes ago that you had worked on disease prevention and things before. So this wasn't entirely a new thing for you. But early on, where were you getting your information to make judgment calls? Was it entirely the CDC, or did you use other sources?
Well, at the beginning, the information was coming from CDC for sure. And then as we started to work on it at a local level, there becomes a matter of, intelligence and data collection at the local level through epidemiology and different forums with the city and the county. So, beginning, February and March, that's where we really started to formulate a lot of intelligence and a lot of data locally.
Can you tell a little bit how you did that? And the reason I ask is because, I read the city of El Paso kind of did a really good job of this and traced where their infections were coming, and they came up that it was mostly from grocery stores. And I guess the reason I'm asking you some of these questions is I want politics-free information. This is a world where people listen to their favorite, provocateur is trying to incite them, not give them valuable information. So I'm glad to have you on to be able to dispel some of these things and to be able to speak straight truth without an agenda. So in your intelligence, did you guys ever discover the spread around the city? What was the most prominent reasons for spread in Houston?
Well, to be completely honest, that would really be a question better answered by the epidemiology team. In my lane of the operations, what we do is, we determine based on the risk assessment, which is based on frequency and severity, which honestly hasn't changed a lot. It's in terms of frequency, we base that on CDC national and global data, and then local collection through testing and hospital information. So we do get a lot of information from the local hospital systems, and then we collect data through our testing. And then from there, we can figure out what the frequency looks like, and we can figure out what the severity looks like in terms of, a combination of factors that epidemiology deals with, and also in terms of, deaths and in terms of hospitalizations. And then they do contact tracing as well, which happens through epidemiology with the health departments. And so from that, we're able to figure out what the risk assessment looks like. And then that tells us what we need to do in terms of prevention. And so then with the preventative efforts, we base that on hierarchy of controls and best practices. So to your point, as far as, apolitical information, and that's a huge thing with me, is I'm always an advocate that safety is definitely not a political issue. It's always a matter of, there's a hazard and there's a hazard control. And then the idea is to, methodologically prevent exposures and injuries and illnesses. So within that, we're able to look at that, first and foremost, if we want to eliminate as much of the risk as possible, then that would be preventing congregations. And so we do that as much as we can within feasibility. And then from there, the next step, of course, is substitution, which, unlike a chemical, the example I always use is, back in the 70s, benzene was used as a solvent. And then we realized, well, I wasn't alive then, but we collectively, people realized that, benzene caused leukemia. And so we realized that other solvents would do the same job without the risk of leukemia. So it's substituted. In the terms of a virus, it doesn't serve any purpose. So the idea is that we want to eliminate the exposures. So the only thing that would count as far as substitution would be if we're talking about, replacing the virus with the antibodies and the vaccines, but the vaccine didn't come around until December of 2020. So then it goes into the engineering controls, which would be, having good ventilation, air changes, circulation, air filtration, MERV 13 filters, all that good stuff. And then we can put barriers between people to block the droplets and create distance between people. If we can't do that, then we go to the administrative controls, which is going to be the capacity limit, so that we're preventing large numbers of droplets in the air. Then we can go to the face covers, which is going to be, a couple different levels there. The intent is to contain the droplets so there's not so many floating around. So you have your generic face cover, like the one I was wearing when I came in. And then, of course, you have surgical mask, which the idea there is that it contains the droplets, but to a level that's acceptable by the FDA. If you have an FDA-approved surgical mask, kind of like if you're doing surgery, a doctor wears an FDA-approved mask to limit the potential of an infection transfer in the OR, things of that nature. And then from there, you have your N95 respirator, which is a level of PPE. So that's one thing we always made sure that people understood was the difference between source control, which is your face cover and your surgical mask, and the difference between that and a PPE, which is a respirator, N95, which is actually governed by, 1910.134, the respiratory protection standard. Then we have, of course, the source control. Then we go to hand hygiene, disinfection, and then, of course, the administrative controls, things like avoiding touching the face and setting up contamination control zones. So we have, hot zones, warm zones, cold zones. Same thing we do for a hazmat incident. And then we can set up regulated medical waste and bio waste disposal to keep things for good contamination control. And then, of course, the last step of that is PPE for the responders. So for the people that absolutely have to be within the 6 feet for more than 15 minutes over 24 hours of someone who's potentially infectious. And then we go to the PPE, which would be the respirator to protect the respiratory tract and the inhalation of the droplets. Then we've got the gloves, nitrile gloves or latex, if there's no allergy, to keep the droplets off the hands, which lessens the chance of them ending up in the face, mouth, eyes, or nose. Then from there, we have the isolation gowns to keep the droplets off the clothes, especially when the clothes are going to be worn home. It keeps the droplets from ending up in the car and in the house. Then the last thing would be things like eye protection or shoe covers, basically anything that keep the droplets off the person. So going down that methodology, what it does is it explains how it's definitely not a situation where, if you belong to this train of thought or this political party, you believe in this, it's, these things exist to serve a purpose to prevent exposures, each in their own way. And that's also why it's so important, where a lot of times there was a misconception where people would feel like, if they do one control, that's good enough. But the intention is that each of those controls serves a different purpose, whether it's to, limit the amount of droplets or to contain the droplets or to keep the droplets off the face or off the hands. So when we implement those things systematically, then it systematically reduces the risk. So we were working on all those things.
But unfortunately, it did get political for a lot of people, and they, they're going to go online and read things, and there's a lot of misinformation. So I guess I'll start with the masks, because that will concern most people more than, the surgical gowns and, the medical professionals. The masks, there's a lot of, do they actually work? What kind of mask actually works? And that's a question out there. So, I understand it as, the N95 is obviously a completely different thing. It's like you said, it's an FDA approved. It's for doctors. It's for people, medical professionals that's got to be within that 6 foot range for an extended period of time. How effective are homemade masks, are cloth masks, are these things? Are they? Do you guys have y'all determined that it was effective enough, or I guess that's the question people want to ask. These, a lot of people are under the impression that cloth mask doesn't even work. It doesn't even stop the droplets. Pose that question to you.
Sure, it's a great question. So there's really two answers to it. The first one is in terms of the need for it. That's the important part, is that it's separate from protection. So the first thing we always impart to people is that the cloth mask especially, and even the surgical mask, even if it's approved by the FDA, those don't serve as protection. So if you're wearing one of those, if you're within the 6 feet, especially within 6 feet for more than 15 minutes over 24 hours of someone who's potentially infectious, it's not going to protect from the exposure. So that's the important part there, is it only serves as source control. So when we say source control, it just contains that person's droplets, and it's not fitted. There's no fit test, so it's not going to contain, up to 95% of down to 0.3 microns like an N95 would. So the intention there is that it only serves as a loose fitting cover just to contain droplets. And so within that context, it is effective. There's a lot of peer reviewed studies, clinical, scientifically based studies. I actually just read another one the other day. I don't remember the source right now, but I can certainly send it to you offline.
Sure.
So it's definitely effective. And then, of course, for the same reason, double masking, it serves to, contain that many more, just because you're putting an overlay over it. So in its own right, for its own reason, it does serve a purpose. So it is very important. And then on the second side of that coin, you have your actual protection, which is where you get into the N95. And that's the other thing we always impart, is that for those people that need an N95, even though it's an N95, it's not like an air purifying respirator or a CBA or, anything of that nature where it's, more durable medical equipment. We're talking about, a filtering face piece, disposable respirator. But because it's intending to filter out those droplets, that's why it's so important that we have the respiratory protection program, which is going to be the medical questionnaire. Reason being is, it's unlike the face cover, where there's also a lot of misconceptions there that the face cover is going to affect the airflow. People feel like it inhibits
absolutely.
their breathing. Scientifically or clinically, it doesn't. Now, of course, some people do have
Psychologically, it does sometimes.
That's true. That's true. And there's also, there are ADA accommodations and things of that nature. So it's not unheard of that people can't wear a face mask or face cover. But generally speaking, the face cover doesn't, impact the breathing like a respirator does. And so with a respirator, because it does impact the breathing, that we want to have that medical questionnaire so that if somebody has something like claustrophobia or a heart condition or respiratory distress, anything of that nature, then we can avoid, putting someone in danger by putting something on their face that's going to inhibit the airflow. And then the second thing is, because it's doing that, we want to make sure that person has training on, what the respirator is and why it's important. And then they're able to get the fit test so they know that it's going to properly filter those droplets or particles, I should say, down to 0.3 microns, 95% of them, as it should. So if somebody's using that as protection, then that entire respiratory protection program is important. Otherwise, it may not do the job, and it could be a false sense of security.
Can you explain a little bit in more details, I guess, in layman's terms, the word droplet? Because I think non-medical people, when they hear that word, they're literally thinking of a raindrop.
Yeah.
And we're not talking about that here. We're talking about something that can't be seen without a microscope, correct?
In a lot of cases, yeah. I mean, in some cases it may be, like we would say, saliva or spit. But in many cases, it's very small, like you said, down to, micron-sized droplets. And that's actually interesting you say that, because that was a source of contention very early on, because originally in the very early stages of the pandemic, the original context was, they say, droplet precautions. And if you're in a healthcare setting, there's a big difference between droplet precautions and airborne precautions. So if you're talking about droplet precautions, that's where you're talking about, source control, surgical masks. And if you're talking about airborne precautions, that's where you're talking about micron-sized droplets, isolation rooms and things of that nature. Things that are aerosol producing, like a bronchoscopy or something of that nature. And so when that started to shift, around March to April of 2020, it went from those, droplet precautions, where there were a lot of organizations early on that, as per the CDC advice, unless they were doing aerosol producing procedures, then they were using, surgical masks. And then it became, okay, we need to go to, if people are going to be in that risk group, they need to be using a respirator, and then everybody else needs to be using the face mask. And so it kind of started to create this kind of transitional phase between droplet precautions and airborne precautions. And, 2020 hindsight, I feel like that may have confused a lot of people back in that phase. And
I think one thing that certainly threw the public off and gave fuel to the fire of the anti-maskers was the federal government coming out and saying, no, you don't need these masks early on. And look, I get it. If they had to do that because we were obviously extremely limited supplies, because China had hoarded them all and they were manufacturing all of them, and they had hoarded them all for their own country. So we didn't have them, and we had to save them for our medical people, because we can't let them get sick, right? I mean, everything, you think it's a disaster, wait till we have no one to be able to take care of these people, and then it's really the worst disaster possible. So I get it. About the spread, early on, it seemed, skin contact, washing the hands was the most important thing, and getting the correct antibacterial to use and things like that. And, I heard a lot of different advice, a lot of different things on how to do it. I have a friend at US AMRID that kind of, told me a little bit about this throughout the life cycle of it. And he, I guess he was more confused early on, or I guess he was more surprised by the unpredictability of this and how different it is and how we really didn't know what to expect. But I guess to get to my question, have we changed since the beginning or how has the knowledge changed of how it spreads from more of a touch to more of a airborne thing? Is it more of the droplets in the air, or is it how much is being transferred by touch?
Definitely true. There's those two things. And that's why those preventative measures are so important. You have the preventative measures that limit and contain the droplets or filter them in the case of respirators. And then you have the hand hygiene disinfection that it's intended to neutralize or remove the droplets on the skin or on common surfaces or things like, pins and elevator buttons and doorknobs. So those two things are equally important for that reason. And, I always encourage, everyone to look at it practically. So if I'm potentially infectious, so if I have COVID-19 and I'm sick, if I come into a room, then, there's an equal probability that if I talk, there's going to be droplets that come out of my mouth and nose. Those are going to land on things like, doorknobs and tabletops and things of that nature. And then you've also got the droplets, they're going to be on my skin, especially if I don't practice good hand hygiene. So if I sneeze on my hands or anything like that, then I'm going to now secondarily transfer those onto those surfaces. So if I put on the face cover and that's going to contain those droplets, and then I wash my hands or put on gloves, that's going to prevent a number of those droplets from ending up on surfaces. So that's really how that kind of boils down. And then same thing as the face mask or the respirators. There is data, of course, that shows how those things are transmitted. And that's going back to that conversation about the droplet precautions versus the airborne precautions. That was a big part of that early on, was the big message, around February to March, wash your hands. And that stayed important, but then it also became put on a mask and wash your hands for that reason. So I think that it certainly wasn't intentional by anybody, but as we kind of went around that learning curve with the virus, it became obvious. Not obvious, I shouldn't say obvious. It became evident that, those two things were equally important. And unfortunately, to your other point, unfortunately, some people that were looking for that political angle, they took that as, a way to try to find fault in it. They would say, see, I told you didn't need the mask, where in reality, it's just a matter of the learning curve and continual improvement, just like anything with safety.
Well, personal opinion, there's nothing, I was in the Army, a saying we always have is, nothing can prepare you for war except war. Nothing can prepare one for a pandemic except a pandemic. And, and unfortunately that's the case. And I think, on every level, we're probably, the citizens were a little too tough on the government, because you had to learn as you go as well and do the best you had with the information you had. Having said that, what do you think the city, because that's who you were, the city, what do you think they did well at the beginning, and what do you wish you could have done better at the beginning in hindsight?
Well, I'll preface this, and it's one thing I tell everybody who'll listen to me, and I absolutely never blow smoke. I only tell the truth as it appears to me. And within that, I can say that I've having done safety for 17 years, ranging from military with things like anthrax and GB and VX, all the way to what we're doing now with pandemics and everything in between. I've been consistently impressed with the way the city's handled it.
Me too.
Thank you. I appreciate that from your perspective. Every conversation we've had, it's been a matter of, okay, well, what's the hazard? What's the risk level, and what are we going to do to prevent it? And then based on that scientific information, I've never come across anybody who, sometimes in safety, you'll come across people that they'll say, well, we're just going to take that risk. If we'd rather, deal with the consequences than have to worry about the preventative measures. But the entire journey, every step of the way, I haven't encountered anybody who has taken that approach. It's always been, what's the most effective way we can prevent exposures, and we're going to do that. And so within that, that it has a lot of finding people that have PPE when the supply lines are dried out, and figuring out how to get these things and train people and make sure we're following all the regulations and, validating these things are being done in real time with operations ranging 669 square miles, a lot of different things going on, and everybody's been willing to do that. So I've been very happy about that. Not to make it about me, at all, but I've never been put in a situation where we say, here's what we recommend, and we had to, had to not do that for whatever reason. It's never been that way. So I haven't had to worry about any kind of ethical dilemmas or anything of that nature where I've had those situations elsewhere, I should say. So that's been a huge blessing. So within that context, things that we've done well, that's the first thing, is just the leadership support, and it's not a political answer. It's just the leadership we have in place. They've been very, transparent, very proactive. And I think that that's a huge thing. They've been willing to listen to the science and made the decisions appropriately. So that's definitely a huge plus. And then within that, everybody on the team, whether it's a health department working on, testing and vaccinations and epidemiology, or whether it's EMS, providing direct care, our clinicians, police department doing law enforcement under pandemic conditions, procurement who deals with, strategic purchasing on this is, of course, falls into that realm. So they've worked on, finding PPE and respirators when the supply lines are dried out and there's issues with, counterfeiting and all kinds of different things that have been in the radar. So everybody's just done a great job. And then as far as improvement, it's it's just a matter of learning, as effectively and efficiently as we can with the information that we have. So I wouldn't say it's a local situation. I would just say that to your point earlier, in terms of the federal response at the time, the one thing it makes me kind of cringe looking back at it. I really wish there wasn't that dichotomy of perspectives. I wish there was, everybody had said, okay, here's the science, here's the unified course of action, and we're all going to attack this the same way. This is something I actually just wrote an article about for AOHP, is that if you look at this in the same lens as you would a hazmat response, we do hazmat responses all the time. So if we had a chemical spill, we would look at it in terms of the first thing is we need a unified decision as far as what the hazard is and what the risk is. So we would say, we have this chemical, it's spilled, it affects these people under this downwind hazard distance. So we're going to implement shelter in place for these people. And everybody agrees on that. There's no question about, well, I don't think the chemical is dangerous, or I don't think these people need to worry about it. This is what we're going to do. And that information goes out. And then from there, we make sure that based on the risk assessment and based on the chemical, we have the right PPE, the right respirators, so the responders are taken care of. And so then within that, there were situations where the PPE wasn't available, or there were issues with, counterfeiting, or, in March of 2020, the FDA had to start issuing emergency use authorizations for, KN95s and things of that nature because there were shortfalls with PPE. Then the next step of that, once the responders are taken care of, we figure out, how far it spread. So in the case of a chemical, we would, do detection and put up the cordon and figure out what the situation is there. So that would go into testing. And we had a lot of situations where testing was actively discouraged, at the federal level, unfortunately, whether directly or, by nuance.
What do you mean it was actively discouraged? Like they were trying to limit the amount of positives in the, I guess, public score of information or realm of information?
Yeah, there were a lot of statements from the federal level where they would say things like, we think that the only reason that there's so many positives is because there's so many tests. So we want to see people quit getting tested. But the reality of that is that if people quit getting tested, then we
can't trace.
Yeah, we don't know who's sick. We don't know how many are sick, and we don't have a sight picture.
So, talking to Mr. Guillory, one of the, I think, most interesting aspects of, what you do and what you did was the tracing. And that's obviously the key to it, right? And by the way, the city of Houston, or the fourth or fifth largest city in America, and you compare it to some of the other large cities. Yeah, we did do very well. I mean, congratulations to everybody. We did very well. We continue to. I keep up with the medical centers information daily that comes out. It looks like we're on a really good pace to improvement. So yeah, everybody on every level did a good job, but the tracing is is very interesting to me, because that is almost an impossible thing to me to think about. So if you could just tell a little bit about your methodology there. Obviously at this point we've moved towards testing, right? We're getting we have a lot more testing availability at this point for you. How did you trace, and how did you decide, okay, we're going to put this kind of testing here? Because, and one more comment before you answer is, I saw everywhere lines. You saw it everywhere. I never saw that here. I don't know what we did differently here in Houston. I don't know what maybe you can speak to that, but other cities, they couldn't get testing. Here, no one ever had that problem. They were in and out in a very orderly manner in a very short period of time. So if you mind, just talk about how you traced, how you did the contact tracing methodology there, and also, how you went about deciding where are we putting our facilities for testing? Where do we mostly need to put them? Where do they need to be the most?
Sure. Well, again, there's a certain, a certain width to the lane that I operate in. So I can't speak on behalf of epidemiology. I can kind of give a concept overview as far as what happens there is, as far as testing, to your first question, the testing started with the sites over at, Butler and Del Mar Stadium back in March of 2020. And so from there, it got rolled out in the same way as we do the vaccinations now, we have the phases. So the first day of testing was first responders, then it went to age groups and medical vulnerabilities, and then it went from there. And thankfully, the testing, we were able to, systematically roll it out in phases, so that, to your point, there wasn't a lot of backlog there. We had some lines at times, but people were able to come in and get a test, whether at a mass testing site or at a community-based testing site, which we're still doing. We have 4 to 6 sites every week. Great testing teams. And so from there, that's been a very comprehensive process. And then within that, what they do is they'll gather the information and the data as far as what the tests show and where those hot spots are popping up. And then from there, they can target where the next testing sites are going to be, and they're able to accommodate. So within that, we can figure out, where the trends are and where the trends, that's a good word for it, where the trends are as far as infections.
Is there are you guys just manually evaluating the data, or is there some type of algorithm for you guys to figure that out for your team?
Well, I'm actually not involved in that myself. That's definitely an epidemiology question. Okay. So I for sake of accuracy, I probably can't get into that too much, but they're very skilled at what they do, and they definitely have a number of different methods of data analysis. And
are they committed to these epidemiologists? Are they committed to the city, or are they working somewhere different than the city contracts, or are they full-time employees?
Epidemiology, there are there's an epidemiology team that's full-time permanent with the health department.
Okay. Yeah.
And then because of the pandemic, there are a lot of team members that are on temporary contracts. Health department's done a enormous amount of hiring in the last year, and just a brilliant job of bringing them on board and making sure that everybody's trained and integrated into the team.
Were you involved personally in, recommendations? It seems the Judge Hidalgo made a lot of these decisions, or almost, all of them. Were you part of the team that made recommendations to her, or as far as what do we shut down? How many people can be in a gathering? What restaurant capacity, et cetera, et cetera? Were you involved in that?
No, that wouldn't be a firsthand thing with me. My role, I would speak with the the health department, and then, like we talked about a minute ago, we go through the methodology in terms of hazard controls, and then based on the information that they have in terms of in terms of infection rates and where those things are appearing. And we would go through, here's what we need to do in terms of preventing exposures. And then they would, the senior leaders would make those decisions in terms of what needs to be, what the recommendations would be in terms of closing things or limiting capacities, and big decisions like stopping the rodeo last year. That's definitely well above my pay grade. So my role is more focused on the tactical level in terms of safety for our teams, and then providing advice in terms of plan review for our partners.
Okay, great. You mentioned earlier there's quite a bit of fraud and I guess with medical equipment, and that's to be expected. We've heard stories. Everyone's read stories. My company is a PPE manufacturer as well, and we've run into it as a problem for us as well as the scam out there. How big of a problem has that been, and what warnings, I guess, would you give to the public about certain types of PPE that they need to be aware of?
Sure. Well, the big thing is, knowing what you're using and what you're using it for. So one of the big things that came out early on was, like we talked about, the difference between a face mask and a respirator. So if you're using a respirator for respirator purposes, meaning that you intend it to filter out, micron-sized particles down to 0.3 microns, 95% of them, then, or N95 or N99, 99% of them, then you want to make sure that you're using a legit N95 respirator. So, of course, the gold standard for that is a NIOSH-approved respirator. So when we look at that,
can you real quickly explain to the audience what NIOSH is?
Oh, sure. Yeah, NIOSH is the National Institute for Occupational Safety and Health. It's a subset or a division of the CDC, Center for Disease Control. And so part of NIOSH's tasking is to provide a approval process on respirators and a lot of equipment that's used for PPE.
And they actually go to manufacturers abroad and approve those facilities, correct?
Yes, sir.
Okay. All right. So go ahead.
Yeah. What they'll do is, they'll look at the specifications for that respirator and determine that if you make this respirator based on these specifications, then we can validate that it will filter, X percentage of particles down to 0.3 microns. And so that's hugely important. So if you have a respirator that's not NIOSH approved, it's a coin toss if it's going to properly filter those particles. And so if it doesn't, then you'll be exposed and you might have a false sense of security. So that's the first step there. And like we talked about, the challenge became when all those NIOSH approved respirators got bought up, then people, okay, well, what do we do now? Because we have to be within the risk group. We have, whether it's a paramedic or whether it's a nurse, these are people that they have to be in that risk area. So that quickly got back to NIOSH. I myself was on the phone with NIOSH for several hours one day. This is before they started issuing emergency use authorizations, EUAs, and we would say, we have people that they have to do COVID-19 testing, and we're not going to put them out there without a respirator, but we can't get N95s. They're NIOSH approved. So we need to know, are these Chinese KN95s, where they work? And so after much, deliberation, NIOSH put out that emergency use authorization on a certain amount of KN95s that they had validated to be similar, if not congruent, to an N95 that was NIOSH approved. And so if you can't get the NIOSH approved, then the next step would be the emergency use authorization, either KN95 or a number of foreign-made respirators. So knowing the difference is very important so that you can validate that it's doing the job it's supposed to. And then the next part of that is that it got a little bit daunting over the course of 2020 and even now, because there were a lot of these what appeared to be a bona fide NIOSH approved N95, like a 3M 1860, which is a fantastic respirator. But it became evident that Customs was seizing a lot of what appeared to be bona fide NIOSH approved respirators, but they were counterfeits. And the counterfeiters got really good at that. So if you look at the news reports on that, you can see the pictures. sometimes you can't tell the difference. They look like bona fide NIOSH approved respirators, but what happened was we started calling, I say we collectively, the safety community, people all over the country, they would get these in hand, and they would call back to manufacturers, whether it be 3M or Honeywell or any number of these people that make N95s, and they would
read off the lot numbers.
Yeah, they bounced the lot numbers.
Yeah, we had to do and find out. This is all the stuff I experienced with our company. Yeah, it's been a roadshow. I mean, it has been something else to overcome, and boy, you don't want to be the ones to supply the wrong product to someone and it not provide them the protection they need. I mean, it was a scary time for everybody, right? Well, the testing is full speed. You may not know the answer to this, or you may not want to comment, but how, I know it's gotten better over time, but how accurate are the tests? How often are we getting false positives, false negatives? And I think that changed over time, right? But early on and now, how often were we getting false positives and false negatives?
Well, there's differences in the rates as far as the efficacy with, or I'm sorry, not efficacy, accuracy, efficacies for the vaccines. There were differences in the rates depending on whether it's the nasal, where they put the Q-tip, it feels like it's touching your brain, versus the swab versus the saliva swab. So there's differences in the accuracy depending on the test.
And you determined that the nasal swab was the best test?
To the best of my knowledge, the most accurate is I can never pronounce it right. It's the nasal pharyngea. I can never pronounce it right, but it's the one where they put that Q-tip way back in the nasal cavity, and that's always been the most effective. Of course, the downside to it is you got to have a trained medical provider to do that, so it doesn't harm the patient. And then, of course, the next step would be the nasal swab, and then I believe the saliva swab is the least accurate. But there are data points on that, but don't quote me on it directly. I don't know them off the top of my head.
Did the inaccuracies? Did you ever have a point where that may have given you the wrong information and you weren't able to set up the testing properly, or it may have skewed your contact tracing methodology at all? Was it ever that bad, or was it pretty close?
No, and again, that's definitely not my lane. My job is to work on the safety protocols and preventative measures for the people that are doing the operations. But within my scope of knowledge, I don't remember any issues where any false positives or anything was causing issues that would limit our effectiveness.
Yeah. So moving forward, we get December. It comes. I guess if you look at historical comparison, the vaccine came at a staggering pace, which again has led the provocateurs to challenge that and to seek out, of course, any vaccine. There's going to be some people that get sick from it. There's going to be some people that have bad reactions to it, no matter what. And they're going to put a big, huge microscope or a big spotlight on that and say, look, this is what's happening. So you're going to be dealing with that. But vaccines are here. We've got them all over the city. I guess my first question is, how did they go about allocating the vaccine? How do we get them here in Houston? And how did you go about allocating it through the city? And I'm asking that not just geographically, but demographically as well.
Again, that's definitely outside of my lane. So from what I know, the allocations, from the federal and state level, down to the cities. From what I know, that happens, up at the state and federal level. And then in terms of the rollout processes, those phases are determined, I believe at that same level in terms of, the phase 1B and phase 1A. So they started with the first responders and the 65 and up vulnerabilities.
The city didn't have any say in that.
No, that's a macro, federal decision to the best of my knowledge. Because those things, actually, you know what? Don't catch me lying. Like I said, I'm not necessarily involved in those decisions. I think there's a state there's a state flexibility, but once again, don't quote me on that. I don't want to speak to something I'm not entirely knowledgeable of.
Okay.
Yeah.
Yeah. I mean, I looked at the numbers recently, and it looks like we're at 23% or 20%. Texas is right now of and of course we did it in the proper, the order, as you said, it come from the federal, whoever it did is based on demographics. I guess I was, this is a personal opinion. I was a little bit indifferent towards, just looking at the pure numbers, and I know that's what you do, and I am to a lesser degree that person too. The medical professionals, they were done first. I didn't necessarily agree with that. And you may have an opinion on it. You might not want to have an opinion on it, but I kind of disagree with that because it didn't seem like they were, number one, susceptible, or number two, have a source of spreading. And I was, I'm thinking, should it be the elderly? Because, if you look at the data, obesity and age, those are the two absolute indicators of what are your culpability if you catch this. And it's like, why didn't it go there first? And I guess, I would love you to be able to answer that, but it sounds like that was not like necessarily something you were involved in creating anyway.
No, I certainly wasn't involved in any of that. That would definitely be, as far as I know, state or federal. Mm-hmm. I can only speculate, in terms of the risk assessment, that would be just based on frequency of exposure. So because you have, medical providers, clinicians, or EMS, or, people that are working with patients, just the fact that they're more likely to have someone sitting right in front of them that has the virus. So the frequency of exposure is much higher, if not, to your point, if not the severity. Mm-hmm. The severity may be lower, but the frequency is definitely higher. So I can only speculate that's why that first phase of vaccine rollouts was for the responders and the medical providers.
Were you involved in the decision making process for like school opening or anything like that?
No.
Were you doing recommendations for that?
No, we didn't make the recommendations as far as the school openings and closings. I did have a role in doing school assistance visits, mm-hmm. So we would work with schools in terms of how to better prevent exposures. So okay. We did a lot of that last summer before the fall semester started, and even now we're helping out schools. So what we do is, we'll go on campus and look at their setups in terms of student counts in the classrooms, distances, barriers, HVAC, ventilation, filtration. We'll look at the nursing as far as what they can do for quarantine and for PPE for the nurses and respirators, and making sure they're protected, and then their contact tracing processes. So we'll go through and do a needs assessment and help them with their safety planning in terms of exposure prevention. And I feel like we've been very successful with that. We've worked with a lot of schools, and they've all been very, very forthcoming in terms of wanting to know how they can improve and how they can get better in terms of that. And
so your team essentially had to rewrite the SOP for every level of government as they slowly started back to somewhat normality or operations at all.
We did a lot of work on that. Whether it was writing it from scratch in terms of algorithms where if you can do this, then do this. If you can't do that, then do this. And we did a lot of peer review and assistance for organizations, whether within the city or partners, external partners. So the one thing I always say about that is, there were, speaking to your point, early on there were a lot of people that were very frustrated and very upset. They felt like, well, people were telling me that we can't operate, but what I would always reinforce is, there's very few things that absolutely cannot be done. If we go through the planning process, we can find a way to do it safely. Sometimes it's resource intensive and sometimes it's, personnel intensive, but typically at the end of the day, there's a way to do things safely for most everything. So that's one of the things we're very proud of, is that we were able to help a lot of people find those ways, so they could continue their operations, or they could have an event, or, whatever it may be. Like I know people would call me and they would see things like, they'd say, well, I saw that they're going to have this whatever it may be, this event here, how are they going to do that without causing a super spreader? And say, well, we've gone through that, and we know that we have a degree of confidence that their plan has enough exposure prevention built into it that they can do it safely. So there's nothing that I saw where I would see something and go, oh my goodness, I can't believe they're doing that. We know that they've gone through the due diligence to do it safely. So we're very happy about that.
Very good. Yeah, I mean, I guess that's the point where, it blurs that line between science and politics, right? And a lot of people, yes, the schools have been a big contention because, the people, the common knowledge is, well, kids aren't really spreading it. Kids aren't really susceptible to it. So why can't they go back to school safely? And it became a political issue. And I guess that's part of, why I wanted to talk to you is because I want people to hear an apolitical person give give facts instead of listening to something that might not quite be true. So moving forward, you got blasted. The big surprise comes. You have this this pandemic thrust upon you. You deal with you coming up with a plan. Doing the testing, doing the contact tracing, and now we're on the vaccines. My question has been for safety managers of private businesses. What are we going to do the next time, this happens? What is our new preparation? What have we learned to help us do better next time?
That's a great question. Like I was saying earlier, to me, the most important thing, if this were to come up again, or when it comes up again, I should say, because, we had near misses. We had Ebola in 2014 and H1N1, avian flu. There's been a lot of things that could have been what COVID-19 ended up being, and COVID-19 could have been worse. So as we look
the original estimate was 2 million dead.
Yes, sir. Yeah, it's scary. Absolutely. So knowing what we know with the good and the bad about this one, which, just for, full transparency, of course, it's not over yet. We're still living with it, and we're still managing it. I would say one of the most integral things is that if this comes up on the radar again, pandemic level, then first things first, we got to have that unified course of action. Based on the risk assessment. I always say, and of course it's easy to armchair quarterback things, but I'd say, if I was the president, of course I would say, here's the situation, here's the hazard, here's the risk. Based on this information, we need everybody to, in this case, limit capacities, social distance, face covers, disinfection, hand hygiene. And then for those that are in those risk groups, care providers, EMS, law enforcement, et cetera, here's the PPE requirements, and then we would do what we can to build that production to where we have those things available and accessible and validated, so there's not the issues with counterfeiting or dry supply lines. And then from there, make sure that, like we're doing in hazmat, first things first, unified course of action, communication.
Was there a unified course of action for the state at all, or was it just, I hear you on the federal. I think one of the primary blocks to that is just simply the way our government is organized. It kind of prevents the federal government, in a lot of cases from mandating things like that. So it is left upon the states. Was there consistency across the state, or was it pretty much mayor to mayor?
Well, short of speaking outside of my scope, I'll just speak to Houston. In terms of what I know here, it's very consistent. It's very much like we said, methodological. Here's the hazard, here's the risk level, here's the necessary exposure prevention, and it was implemented as such. Even now, last week, of course, we had the change in the state mandate, and it took a matter of hours. The city looked at the information and the intelligence, and here's the risk level. We're going to continue with what we're doing. The city has AP 3-39, which is the administrative procedure in terms of entering city facilities with, face covers, social distancing, capacity limits. And so everything's been very consistent. There hasn't been pushback on that.
I'm not speaking for you, but it kind of seems there is light at the end of the tunnel now for this, at least a little bit in some cases. Do you see a point in the near future where I guess this would be your opinion, when we can, I guess, be back perfectly normal, when masks aren't really needed, even as an opinion? Like, you said you should wear a mask, even though the contract, getting it is gone way down. The chances of getting it's gone way down. The spread is low. And I guess my question is, how close are we to complete normality?
That's a great question. I wish I could answer it. I kind of look at it, one battle at a time, to be honest. And so within that, we've got to reduce the frequency of exposure and we've got to reduce the severity of exposure. So to do that, that would require frequency would be, continued exposure prevention, and then vaccines. And then the vaccine kind of segues into the severity, which means that if people got the virus, then the outcome would be less severe. And then we have, increases just over the last year. We've had progress in terms of medical treatment and in terms of, acquisitions of, medications and medical equipment and things that are necessary. So there's been a lot of great strides there, and each of those strides, puts a dent in it in the long run. So the more that we have, continued exposure prevention, which we talked about with the, the hazard control methodology, and then the vaccines, and then the testing still plays into that in terms of, having the situational awareness and the site picture. And then that transitions into the vaccine and the medical treatment. So we can lower the frequency and severity to the point where it becomes safe to live without the face covers. And then the last step of that would be to live without the, the social distancing, and then would at some point be back to where we were in December of 2019. But I couldn't say when that would be, with any level of accuracy right now.
Is it based on the idea? Do you guys base it on the idea of herd immunity?
That would be a better question for the, for the epidemiology team. In my case, like I said, I look at it, battle to battle. So in terms of prevention, if we can go from, day to day and from milestone to milestone with fewer people getting sick, and then those that do get sick, less catastrophic outcomes, then we're doing better each time. And then eventually that'll lead to that point. But, where we get to the point where we have enough immunity in society to where we can live without the mask and the distancing. I couldn't say when that will be, but that's what we have to get to.
A lot of manufacturing is done in Asia, and I've been there, travel there quite a bit, for work, and, masks are much more of a normal thing there. It's something society has become comfortable with and wearing. And I tell people this, and it's hard to believe, but when it first happened, the name, obviously, Wuhan came up, and I saw Wuhan, and it just rang a bell with me. And I was thinking, is that the city I had a layover in, 11-hour layover in, coming from Cambodia back to the United States? And I looked back and I looked at my travel documents, and sure enough, September 27th of 2019, I was in Wuhan for half a day. And I made a cognizant decision at the last minute not to go into town. I stayed at the airport, and I got a hotel room and took a nap instead, by sheer miracle, because obviously it was already there then. Or probably was, moving around Wuhan. And I sit back and I think about it, and the chances I could have been patient zero scare me. I really could have been, because it was that early, and it was that at that point, and I was like, ooh, whatever made me, however tired I was, whatever decision I made, I'm glad I didn't go down there and do it. But thank you very much for coming in and to sharing with us your expertise in this, what happened. The more we know, or I guess the more everyone knows, the more society knows, the more information they have, the more accurate information, I think we'll be better off. So I think it's important, for people that do what you do to share, what's happened, what you think, and why we are doing certain things. And for that, I thank you very much for coming in and doing that.
I appreciate the invitation. I hope it was helpful. Like anything, there's a lot that I work with, but I'm not the person to speak to directly as far as, epidemiology processes and whatnot. But I can attest that the people that do that are subject matter experts. They're very dedicated and very good at what they do. And everybody's definitely got, the greater good in mind and just wants to see people well. So the more we can do that, each of us plays our role in terms of exposure prevention and recovery from the pandemic. But I hope it was helpful. Appreciate it.
It was, and personally, from me to you, a real thank you for you and your team. And we owe you. There's a reason we're still able to go to restaurants, and there's a reason we're able to still go to our grocery store safely, and it was because of the work you guys did. And thank you very much for that.
Thank you all. It's certainly a person-to-person effort. If everybody didn't take it to heart, and whether it's wearing the face cover or keeping the 6 feet apart like we are now, or or washing their hands, in every business and every individual, that's what makes it happen. And as far as our team members and our coworkers, each one of them is certainly pulled their weight plus some. So I was actually just having that conversation yesterday with some of our team leaders on the incident command, and I said, I can show up and provide all the recommendations in the world, but if y'all didn't implement those things and drive that culture so that each team member actively, did things the safest way, then it really wouldn't matter what I do, because there would still be a lot of exposures, but the fact that there's not, I'm sorry?
Gotta have follow through.
Absolutely. Yeah, the fact that there hasn't been is a testament to how diligent they are,
Well, thank you very much for stopping by, and that'll end us there.
Thank you for listening. We hope you enjoyed the show and accept the mission. Please subscribe to the Mission Zero podcast on your preferred streaming service, and be sure to give us a 5-star review.